Greeting everyone. I am Dr. Deependra and I welcome you all in today's connect session with Shailesh sir. And today sir is going to continue with second part of fracture related infection. So I think this talk is going to be very useful to all of you. So without any further delay, I welcome you sir on the board and I request you to start your presentation. Now it's over to you, Dr. Shailesh sir.
Thanks, Dr. Deependra. Hi friends and welcome to this session. We'll be continuing with fracture related infections that we did last week. So today it will be treatment. Okay, so this is regarding the treatment of fracture related infections. We have gone through how to diagnose it, what are the investigations we do, and how do we prevent fracture related infection. Now once we have the diagnosis, how do we treat it is the question. Now the principles all are pretty straightforward. All of us know how to treat infection and how to treat fractures. But thing is, many times it can get a little tricky depending on the situation. Now, that's exactly where we need some guidelines and recommendations, and that's the entire basis for this talk. So there's something called this SOSTAC strategy. Now, this is not for fracture-related infection as such. This is a strategy that we can use in any management services, right? So what is SOSTAC? S stands for situation analysis, that we need to first analyze what exactly is the issue right now, where do we stand now. Okay, then we see the objectives that, okay, we are in this position and where do we want ourselves to be. Then we strategize whatever our end goal is to reach there, what all we need to do. And to do that, what all tactics we need to employ and what actions we take, and then how do we control and what do we monitor. Now, these is as such management plans whenever there is any issue, any problem. Now, fracture-related infection is one of the biggest problem that a trauma surgeon may face, and hence, if he starts thinking in these terms, it makes things easier. Okay, so what do we do to analyze the situation? Now, we need to first see, whenever we diagnose that the patient has a fracture-related infection, the first and foremost thought should be, why did this patient end up with infection? Right? Even though the incidence tells us it is about 1 to 3%, but why did this particular patient end up with infection? Now, to do that, first we need to see whether he has any systemic comorbidities, like whether he's a diabetic, whether he's a smoker, whether he has any endocrinological problems. All those we need to assess. Many times we might have missed out. Sometimes we might think, say, a 20, 25-year-old gentleman does not have diabetes, we won't even investigate. But when we go into analysis, we do realize that even those patients can have, right? So we should not take anything for granted. Better to analyze them, even if we miss out during fracture treatment. But if the patient comes back with an infection, we need to once again start the detailed line of investigations. Local comorbidity means whether this patient has a peripheral vascular disease, any local issues, skin healing problems, that led to some problems with the wound healing, thereby leading on to infection. This is what we need to start analyzing. Okay. Once we do all that, then we need to know what is the social context and the support of this patient. In a sense, once we diagnose that the patient has a fracture-related infection, it is going to be a long duration of multiple surgeries, rehabilitation, thereby delaying the patient getting back to his normal functional status, right? So we need to understand that how much support he has, because if the patient doesn't have enough support, he might lose the willingness to continue with the treatment, right? Many times we do see that the patient is fed up with the treatment and comes and asks for an amputation, secondary amputation. So might end up even in amputation when there is a florid infection, not responding to treatment at all. So all these things we need to consider on day one, that, okay, things have gone wrong, but what could be the cause, whether the patient has any problems per se from his perspective, and if we go on the particular pathway of treatment, how much support can we expect from his side and from his other attenders that he has. Okay. Then look into, now most of these fractures which end up with infection are operated fractures. The close management of injury is rarely, once we tell that they are operated, that means there is some sort of an implant inside. So we need to decide what type of an implant is it there, whether it is an X-Pig snail, K-wire, plate, any other thing, SS wires, Surcage wires, all those things could be there. So assess what type of implant is there and what is the stability that the implant is providing. Okay, whether it is stable enough, whether the implant is stable within the bone, plus whether the implant is providing enough stability to the bone. Both of these are actually different. Okay. So implant may be loose, or implant may be stable enough, but overall the stability may be not adequate for the fracture. So all those things we need to start assessing. And time since implantation. So when was the surgery done, whether it is 2 weeks, 4 weeks, 2 months, 2 years, whatever. So we need to start assessing that when was this particular implant put. Why is that important? No, that is because arbitrary on timeline, it is understood that about 8 to 10 weeks down the line, if the infection is persisting, that means by all chances biofilm is formed. And once the biofilm is formed, the treatment of that particular infection becomes much more difficult. So that is what the cutoff is, that if the implant is more than that, then we need to start thinking and worrying more. Okay. Now this 10 weeks is what is the routine thing mentioned. The current recommendations are different. We'll come to that when we come to that slide. But as of now, remember, it is 10 weeks for biofilm. Okay, it has nothing to do with the treatment guidelines. And then look into what is happening to the fracture. Where in the bone is the fracture? That is an articular fracture, metaphyseal fracture, diaphyseal fracture. If it's an articular fracture, then this infection is ending up in septic arthritis, and we need a much more stabler implant. Okay. And what is happening to the union as such? Bone consolidation means bone healing, whether the callus is forming, whether the bone is healing, nearly healing, all those. Because if it is such that the patient is having infection and the bone is nearly healing, then we can do minimal thing what is required. We'll come to that a little later, and wait for the union to come, so that once the union happens, we can remove the implant safely and at the same time do the thorough debridement that is required, right? So even that perspective, you start thinking whether we can wait for a little more time for the bone to heal, or we need to intervene early and do something. Okay. Of course, reduction quality is what we told in the previous thing. How much stability is provided by the implant to the bone, and what is the quality of the reduction. You might see that the implant is very rigidly fixed, but the reduction is just not acceptable, not within the acceptable parameters. Then it is worthwhile removing that implant, because even if the patient heals, the patient is not going to do good. So that is where we can decide, okay, this patient reduction is not great, so this implant serves no purpose. So we would rather remove that. That helps in the eradication of infection also. And we need to also see whether there are bone defects per se. Now, if there are bony defects, then we need to start thinking what needs to be done for that bony defect. Okay, that is regarding the fracture. Then regarding the organism, this is the different things that we analyze. What have we grown? What is the culture sensitivity of that particular organism? Okay, and whether an oral antibiotics are possible. Now, for example, there may be some antibiotics which are, I mean, the particular organism may be sensitive to only a particular antibiotic which is only available parenterally. And we all know in infections, almost for about 3 months, 6 weeks to 3 months, we need to be giving these antibiotics. It becomes difficult for us to give that much for a long duration parenterally. So if oral it is available, it makes much more easier and better compliance from the patient. Okay. And then you should also start thinking of from the toxicity point of view, that when we're giving the antibiotic for such a long time, what are the adverse reactions that the patient can have, right? So in this especially, cross consultation with either the infectious disease specialist or the general physician makes much more sense, because our knowledge regarding all of this is very limited. So these are the 4 different things that we start thinking when we diagnose a FRI, that whether it is because of the host related problems, what is happening to the implant, what is happening to the fracture, and what about the organisms, microorganisms. Okay. So once we analyze that, then we move on to the objectives. Now, objectives in any fracture related infection is pretty simple. We need to control the infection, right? We need to make the skin heal, that is soft tissues heal. We need to make the bone heal, fracture consolidation, and we have to prevent this infection from becoming a chronic infection, and the patient should get back to his functional that he had before he had the fracture, right? So restoration of his function is also of prime importance. So all of these we need to start thinking into. What do we do? I mean, how do we control infection? How do we make the bone to heal? How do we make the skin to heal? How do we prevent this particular infection from becoming chronic? And what do we do so that the patient gets back almost all his functions, right? So in this, there are the different strategies that we employ. So many of the times we do one of these strategies. It has to be one amongst these 5, right? So there is something called DARE. DARE means we debride, give antibiotics, and retain the implant. IR is implant retention. That is DARE strategy. The second one is we can exchange the implant. Okay, so remove a particular implant and put in one other implant. The third thing that we can do is Ilizaro external fixator with distraction osteogenesis. Other thing that we can do is, if especially if there's a bone gap, is we can put bone grafts or spacers. So these may be bone substitutes coated with antibiotics. The last one is amputation. So we can mix and match some of these whenever we treat any patient with fracture-related infection. So these are the only things that can be done. Right? So we need to strategize ourselves into one of these. So how do we decide it's on this particular